Hi guys. So for those guys who haven't met me yet or know me, I'm Shanthosh. I'm a cardiologist by training. I'm doing my PhD with Sam. So we're going to talk to you about aortic stenosis in a couple of cases that we've compiled together. Uh, and from what I can gather, a number of you are fairly new to echo and echo interpretation. So we'll take it reasonably slow, and some of you are reasonably advanced and know what you're dealing with. So I'll go through how to do the assessment of aortic stenosis, and then we'll go through a couple of cases and how to interpret that, and then we can go from there. So aortic stenosis, in terms of just the echo or main measurements of the echo, there's a number of parameters that we look at in terms of trying to figure out what the severity of the aortic stenosis is, whether it's mild, moderate, and severe. And I'm going to give you a table based on the ASC guidelines as to how to grade these guys. But there are also other ways of parameters that we can measure or grade the severity, and we can go through that a bit later on as well in this talk. One of the main things when you guys do the aortic stenosis, I mean, the reason why aortic stenosis is so important is because as the severity increases, the mortality also increases. And so as soon as they get to severe aortic stenosis, their mortality is quite high. And so that's why it's quite important in terms of trying to figure out what's going on. But not only that, the patients that you guys will have particularly whether it's in ED or in the critical care, like in ICU setting, when someone comes in with, aortic stenosis or severe aortic stenosis, it really impacts on how their hemodynamics works and what happens, particularly when you flog them with inotropes or catecholamines, and how they respond to all of that. So it's important to kind of figure out, okay, well, does this person have aortic stenosis, yes or no, and what is the severity of aortic stenosis? And then we'll go through those motions first. I don't think we need to go through the pathophysiology or all of that. I think we can skip that. So I'll just go straight into where the money is, and then we can go from there. So one of the main ways that we try and or measurements or parameters that we define aortic stenosis is through obtaining the peak velocity. So what we do is we put in the 5-chamber view. So this is where your aorta is slightly opened up. We put the cursor or the continuous wave just close to the aortic valve. And then we measure using the Doppler to try and figure out what the peak aortic velocity is at this, using that jet. Now, one of the ways that I know exactly where I am, you guys may know, when we do, so we've got the 5-chamber view, you open up, so you've done your 4-chamber, you open it up so they get the 5-chamber view with the LVOT. We put the Doppler trace just near the aortic valve. And you guys may know, how do I know that if this Doppler trace is at an accurate location? Anyone? Pretty simple in terms of looking at the Doppler. We look at the opening and closing click. So if you have the opening and closing click, then you know that you've got the right trace. If you've only got the closing click, then that means you're too far away, and if you've got no clicks, then you're nowhere near the chamber. So that's one of the ways of trying to figure out, or correct yourself and say, okay, well, do I have an opening and closing click? In which case, this Doppler trace does not, and so I would optimize that to ensure that that I'm getting the right correct measurements. For the peak velocity, the Doppler profile itself is quite helpful in trying to figure out what the severity is. For mild aortic stenosis, you generally get a more of a triangular form, and it's like early peaking. For when you've got severe obstruction, the velocity occurs later in systole, and the curve is more rounded. So looking at the curves itself will give you a bit of a clue as to what the severity is. And that's usually sometimes it's a good question and say, okay, well, what is the severity by just looking at the Doppler profile? So I think it's important to be mindful of that. Does anyone know what this is behind it? It's a bit denser. Sorry, Drew, I can't hear you. Hang on. You may need to unmute yourself. Hello? Sorry, dude.
Sorry, dude.
I still can't hear you. That's okay. It's the LVOT VTI, velocity. So don't get confused in terms of what's happening from behind that. So that's an important thing. We'll look at the transvalvular gradient, and this is using the Bernoulli equation, which is based on the law of conservation of mass, which essentially states that energy in an isolated system remains constant. You can't create it or destroy it. It only can be transformed or transferred from one form to another. So blood flow through the heart vessels obey the same laws of conservation of energy. And essentially what we end up with by using this and kind of ignoring the viscous element and the inertial elements and so forth, we assume that they're negligent, and we know that they're kind of negligent. We get a simplified Bernoulli equation. And that way we can kind of equate or calculate what the transvalvular gradient is. And it's essentially change in pressure is 4V squared. This becomes important because that's how we kind of, also obtain, the mean gradients and so forth. And the mean gradient in this case is obtained by averaging the instantaneous gradients over the ejection period, and is derived from the trace of the velocity curve. And when you trace it, the program automatically will give you a recording or a measurement of what the mean gradient is. So we look at both the peak and the mean gradient. In this case, again, I would like to just highlight the fact that they don't have an opening click. They do have a closing click, but it's important that if I want to get a correct measurement or alignment, it's kind of a self-check, or kind of like another way to check whether the other person who's measured the aortic stenosis has done it correctly. For measuring what the actual aortic valve area is, what we do is use the continuity principle. In other words, blood flow going in equals blood flow going out. And if we know what the area of one of the variables are, we can try and figure out, we'll be able to figure out what the area of the other variable is. So A1 times V1 will equal to A2 times V2. And if you rearrange the equation, you'll get A2, which is what we're trying to figure out in terms of what the aortic valve area is equal to aortic area 1 times velocity 1 over velocity 2. Now, area 1 is your LVOT diameter, which I'll go through in the next slide in terms of how to measure that. So if you know what your LVOT diameter is, and your V1, which is your LVOT VTI, and then your V2, which is your aortic valve velocity, you'll be able to figure out what the area of the aorta is. So looking at this is your parasternal long axis view. You measure the LVOT just within about half a centimeter from the cusp insertion points. And that's probably the ballpark figures. I mean, there's been studies out there in terms of whether you actually measure at the cusp or just a half centimeter within, and then generally the rule of thumb is within half a centimeter is what's appropriate currently at the moment. So if you know what your LVOT VTI is, your LVOT diameter, you will then be able to figure out what your LVOT VTI is by measuring the VTI that. Then you'll be able to figure out what the aortic valve area is subsequently. So looking at this slide, if I measure the aortic LVOT VTI, if I take that trace, I'll get a velocity of that. Then using that equation, I'll be able to figure out what the aortic valve area is. we sometimes can also use planimetry to try and figure out what the actual area is. The problem is that it's not as accurate when, particularly in terms of when you do the TTE or transthoracic, because it really depends on the plane that you take that measurement. And particularly if it's very calcified, in which case most of the time in severe cases the valve is, that it's the accuracy of this planimetry is questionable. It is better with toe imaging, and you can do that. But then again, I think there was a study done where it looked at if you did all the planimetries and kind of said, okay, what is the actual area, orifice of the opening of the aortic valve? It was so variable because it really depends on if you can, hopefully you can see my mouse. If it depends, do I go that far in? I can't really see it. It's so fudgy. And so you get a lot of different measurements, but it can try and help you to, be another referee and say, well, is this severe? Is this or is this moderate, or what the orifice is? So it's an adjunct or another parameter to try and help you out to figure what the severity is if you're not sure, or if some of the parameters are in the moderate and some of them are in the severe, and you're trying to, toss between whether this valve is moderate or severe. Remember, Sam does not like moderate to severe grading or mild to moderate, so he'll pin you down on it. But it is something that we use, and I think particularly in structural heart disease, and the structural heart physicians will generally also use this and other adjuncts to try and figure out the severity of the valve. This is, I think, a great tool. It's called Dimensionless Index, or DI. And what it does is it removes the equation of what the LVOT diameter measurement is. So one of the approaches by reducing the error related to the LVOT diameter, because remember, if I go back here, it depends on where I've taken the measurement. If I'm too far out, I'm going to get a different area of the LVOT area, and if I'm too close in, I'm going to get much more narrow. Then the other thing is the plane at which you cut the image at. One of the other assumptions is that the LVOT is round or cylindrical, essentially, and that is not the case. We know that the LVOT VTI is more ovoid, but the assumption for this diameter is that it is a circle for this to work. And so because of that error in terms of measurement, you can get variations in your aortic valve area measurements. So by removing the cross-sectional issue, or moving this, we can just focus on what the dimensionless index is, which is looking at the aortic LVOT VTI over the aortic valve VTI, and we get what's called a dimensionless index. It is essentially a ratio of the subvalvular velocity obtained, which you obtain through the pulse wave of the LVOT, and then by the continuous wave of the Doppler across the aortic valve. And in the absence of aortic stenosis, the velocity should approach 1. In other words, what goes in, what goes out. There's smaller numbers if there's a smaller number, or the ratio, it indicates that there is this element of stenosis. And so what they've done is they've graded it. And if you get a dimensionless index, or a DSI of 0.25 or less, it corresponds to a valve area of 25% of normal, and that is what they've graded as severe. So if you look at this, the ESC AHA guideline, if you include a number of the parameters together, we talked about peak velocity, and a peak velocity of more than 4 meters per second is considered severe. Mean gradient of more than 40 is severe. Aortic valve area of less than 1, and a dimensionless index, and they've called it velocity ratio in this case of less than 0.25. These are all parameters to try and help to say that this valve is severe. Now, I find it usually difficult to remember all of the other parameters, but if you remember what severe is, you can kind of figure out where you stand in terms of what. Otherwise, just pull out over and over again, and you'll kind of eventually remember it. But more than peak velocity of more than 4, mean gradient of more than 40, and an aortic valve area of less than 1, and you can also use dimensionless index. And usually, obviously, in medicine, you'll never get, not always will you get all of the severe parameters, because of variations, obviously. So then you try and look at other parameters or adjunct parameters to try and help you to determine whether this valve, excuse me, is moderate or severe. Does that make sense so far? Any questions? Sorry, I didn't realize, Ramani, you had your hand up.
Just a quick one. I mean, it's silly, very rookie question. You did say continuous wave, not a pulse wave, for dimensionless index. Any particular reason why we choose one over the other in this situation?
Yeah, I mean, you use a pulse wave for the VTIs, for the LVOT. I don't know, to be honest, is the answer why we use one or the other. I suspect probably something to do with physics, but I don't know.
Sure. No,
Okay.
yeah, I agree. No issues. Yeah.
Anyone else? Drew, you okay?
Yeah, I think I got my microphone working.
It's working.
Shanthosh, just tell me, it's something in the back of my head. Is there a difference between the functional valve area and the anatomical, and how we're more interested in the functional? Is that true, which makes planimetry less useful? Is there any truth to that, or am I just making that up?
Yeah, I think there is some truth to that. We're more interested in terms of the functional, because that's actually what is clinically, I guess, relevant as such. And that's why planimetry becomes really, really messy when you use it as a tool to try and grade your severity. To be honest, I rarely use it in clinical practice. If I'm not sure, and kind of helps me or for fun, but I don't. Yeah, it becomes a bit messy.
Yeah, thanks.
All right. So let's start off with a couple of histories, or sorry, a couple of cases. 28-year-old man with end-stage renal failure, elevated BMI, presents with dyspnea. Does anyone want to comment on the parasternal long?
I think I'm your man today, if anyone else wants to jump in. But so I guess given the age, you have to be really suspicious for bicuspid aortic valve. So I guess we'll just start with that. It's a parasternal long axis. There's asymmetric ventricular hypertrophy. The ejection fraction's reduced, probably about 45%, but probably not a good indication of the true cardiac performance. The left atrium's dilated. There's tethering of the mitral valve leaflets, and the posterior mitral valve leaflet appears tethered. I suspect some degree of mitral regurgitation. The aortic valve is calcified. The right coronary cusp is calcified and thickened. I can't appreciate, there is excursion, but it is reduced. The other coronary cusp, which could be the left or the non, shows some mild calcification and probably normal excursion, but I'd look at it different views, of course. There's a trivial pericardial effusion. The right ventricular size and function, RVOT size and function, appears normal.
Absolutely. I mean, that's a great example, and Drew, that was great. What Drew did exactly, I mean, he's done this. This is not his first rodeo, but for all the other guys, I mean, I know we're talking about the aortic valve. It's very important to look at the whole picture and the rest of the echo or the parameters or the valves that you have. And so you generally look at everything else. And Drew said, yes, the LV is thickened. And this is, abnormal for a young 28-year-old guy. And maybe it's a bit too hard. It looks a bit speckled, but I don't know. That's hard, but that's, we can put that in the backside. But definitely thickened ventricle. And the LV function, which is crucial in terms of the fact that you commented on, it looks okay, but I think it is definitely at least mildly reduced. But remember, this is a 28-year-old guy. He should have a much higher contractility. So this is definitely reduced, if not moderate. So that's something that you have to be mindful of, particularly when you're doing the aortic valve assessment, because if you don't have enough force or velocity to push blood across the valve, you can't get the appropriate gradients across that. So that's an important factor. The other thing is, Drew rightfully mentioned the other valve, the mitral valve, that you can see the posterior leaflet is tethered there. So if you can appreciate that. The RV looks reduced in terms of its function as well. And there's a bit of pericardial effusion. So yes, we're talking about the aortic valve, but Drew rightfully went and looked at the whole picture on the echo. So rightfully, from the get-go, he knows that the LV is down. He knows that the LV is thickened. He knows that this is, probably another valve involved, apart from the aortic valve. So that's something that gives you a good clue as to trying to figure out, okay, well, what am I going to focus on as I'm going to go through the study? Anything with this one, Drew?
Yep, so this is a zoomed in view of the aortic valve. On the left is just 2D and on the right is color. The left, again, you can appreciate the thickening of the right coronary cusp, particularly at the insertion of the leaflet. And the excursion, as previously discussed, is reduced. The aortic root doesn't look dilated, which is a key point in a bicuspid aortic valve. I'd want to assess the ascending aorta as well. And from color, I can just see a trivial posteriorly directed aortic regurgitation jet. I'd further want to evaluate that, and I can tell you all about that. But that's not out of keeping with what can happen with a bicuspid aortic valve. Okay. This is an LVOT measurement. Do you want me to keep going?
Yeah, absolutely.
Yep, LVOT measurement, diameter measurement. I acknowledge that this can sometimes be a very tricky evaluation in a lot of patients to get that perpendicular measurement, and it is a bit oblique on this particular view. I'd look at the sine loop and just make sure that I was measuring at the insertion of the cusps. The calcification, you wouldn't include the calcification in the measurement just to get the true LVOT diameter.
Yeah, absolutely. If I gave you an LVOT diameter of 18 or 17, I'd
be concerned it was underestimated.
Yeah, absolutely. So that's just a small side note that if you ever see that, 17 or 18, either they're very small, but on an average adult, you probably want to remeasure that again and say, oh, I may have made an error with that. Yeah, absolutely. So I think moving on. Anything else that you can glean of this?
Quality is not great. I can't see any hint of it's not a dedicated assessment to the mitral valve, and I can't see any evidence of regurgitation. This is a zoomed in view. So the non-coronary cusp shows good excursion. The right coronary cusp is thickened and it has slightly reduced excursion. And left coronary cusp is poorly visible.
Does everyone know how to tell which one's the non and the right? So if you with the intra-aortic septum, it's usually the N. So you're going, clockwise NRL. That's one of the mnemonics that I use to try and help myself. It's important to anchor yourself to the intra-aortic septum, because in the toe images it's upside down, it's opposite, so they can trick you with that. So that's just one of the ways to try and help you out. Okay, so we've got calcified. It looks like it's opening okay, but heavily calcified. This is through the mitral valve.
Yeah, I can't be confident with the morphology, I guess, with that one. The mitral, so this is the peristernal short axis view, level of the mitral valve, and now on the right is the pap muscle view, the mid view. I guess you can appreciate a small pericardial effusion. The mitral valves doesn't appear to be stenotic visually. There's good opening. I guess from a function perspective, appears globally reduced. I can't appreciate any regional wall motion abnormalities yet. And that's about it. Okay, so 4-chamber view, a little bit of lag. What can I tell you? I guess the left, that's better. Left ventricular function is still, keeping in the context, but numerically, I think would be mild, in the 45% range. Still tethering of the valve. Small pericardial effusion again. Right ventricular size appears normal. The function visually appears reduced, both in the radial and in the longitudinal. We've got color now over the. Oh,
Sorry.
that's good. And then this is the 2-chamber and the 3-chamber views. Again, I can't see any obvious regional wall motion abnormalities, but the endocardial definition isn't optimal.
It's not great.
Contrast study would assist with this.
Yeah, absolutely. So going to the money shots.
Okay, so what you can appreciate here is a peak of 4.19 meters per second, which is based on the ESC criteria in the severe range, although it's a multi-parametric approach. The mean gradient is 43, again, in keeping with severe stenosis. I think it is a good measurement. You can see the clicks, the waveform, and that there's a relatively late peak to it. The VTI is 15.6, which perhaps I would want to do that one. It's roughly normal, although it may be underestimated, I think. But
Don't have closing clicks, so I'll probably try and see if I can optimize that further. This one's probably really
that's a closing click there. Yeah.
But then the envelope again, it's not that crisp. So
no. If you underestimate it, you'll get a DPI that's a bit more severe.
So putting it all together.
So in summary, I guess there's a patient with left ventricular dysfunction with, I guess, Doppler evidence of severe aortic stenosis, although it seems incongruent with some of the 2D findings of the aortic valve. I'm considering some of the pitfalls, and I'd have to consider the blood pressure as well. But ultimately, I think this is in keeping with severe aortic stenosis.
Yeah, absolutely. In this case, it's 100%. Ramani, I do apologize. We're supposed to be using aortic valve VTIs, not LVOT, so continuous wave, for the DSIs. So we're supposed to be using that AV VTI measurements when we do the dimensionless index measurement. So LVOT VTI over AV VTI. So using that equation, 15.6 over 80, what do we get in terms of dimensionless index?
Less than 0.25.
Yeah, absolutely. So it's, I just did it quickly on the calculator, it's like 0.2 or something. So yeah. Yep. So that also is in keeping with severe aortic stenosis. So you've got multiple parameters which are hitting the targets of severe aortic stenosis. The valve, although looks like it's opening, the thing that you also mentioned is I suspect the gradients are going to be much higher because the LV is down, right? So you've got at least, you said mild, maybe I might think it might be moderate, particularly for a young guy. It is reduced. He's got end-stage renal failure. My question is whether he's on dialysis, because the dialysis guys will have a much higher output state. The LVs will be again contracting. So the gradient, I think, is underestimated in this case, and I would say this is definitely severe. in fact, I believe this case was where it was underestimated for a long time and wasn't really recognized that this guy had severe aortic stenosis. So that's one of the pitfalls, and just important to remember that the young patients generally you can get caught off guard. The other thing is a young guy with signs of aortic stenosis, you think that this is probably bicuspid, okay? But I suspect in this case multifactorial is that end-stage renal failure. There's probably something else going on in this guy, but definitely I would be interested. It's hard to say whether it was bicuspid on this view because the images weren't that great, but you would definitely be looking at that, so in doing a toe and so forth, or to try and figure out if it is. Or you could do a CT, a cardiac CT, and that will also help you. Does that sound fair enough? Any questions about that? So pretty straightforward. Ramani?
Quick one. Do you have a preference in terms of the specificity of diagnosis? The dimensionless index might have better specificity is what I'm thinking, my simple mind, that you're eliminating the errors that can be added by using the volumes or the area, sorry. Has it been borne out by some research at the back end saying this index is better than the other one, or we actually have to most of the times use all four of them?
You have to use all four of them. Well, not four of them, but at least most of the parameters. Definitely Vmax and the mean gradient, and the dimensionless index is great because it removes all that error. So I agree. I would use that as well, particularly when you're communicating to another physician or a clinician. They'll use all of that parameters, but the guidelines dictate that you definitely use the Vmax and mean gradient, particularly also for serial measurements.
Sure.
So that's where, that's what we use, but you can't just basically go dimensionless index and just go away with it. But where it's important is, say, for example, if you've got a Vmax of 3.5, okay, it's just less than that, and the mean is just hovering around under 40, it's not just 40, and then you use dimensionless index to really try and help you out to figure out whether, well, hang on, is this moderate or severe? And then you go back and just make sure your measurements are also correct. So I think that's where it's quite helpful in those settings.
So am I hearing you correct that if you have a poor ejection fraction, you might actually rely on it more than?
Absolutely.
Yeah. Okay.
Absolutely, because your gradients will be not enough to go to get the mean gradients that you desire. Case 2. Ramana, do you want to have a crack? You were quiet. So I've just highlighted a couple of things, but yeah.
Yeah, the planimetry size of 1.2 is just in the moderate category. It's not severe. Anything below 1 is severe. I can't comment much about the image quality. It looks okay to me, to be honest, for the planimetry at least. But should it not be mid-systole? It's like dot at systole, the measurement. Just looking at the ECG trace. If that is if that is the case, maybe I would want to look at the images myself and see if that's the maximum opening. And that's the only comment on first image. The second image also is just looking at the shape of the continuous wave Doppler through the aortic valve has both opening and closing click, and it is a bit more rounded than what I would like for a normal valve. Just commenting on the shape at the moment. Looking at the area, so the mean gradient is 18 and the max pressure gradient is 29. They can't from the top of my head, but they come in the mild category as well. And aortic valve VTI is 49, which I'll keep in mind. Going down to the LVOT VTI, but bearing in mind it is pulse wave, not continuous wave. The ratio is almost 0.33 or 0.35. So again, this is in the moderate category. And LVOT VTI as such is 15.4. I would like to average out those numbers, because if you see the VTI before and after, they look to be different. And this LVOT VTI, bearing in mind the opening and the closing click both are actually visible, so it's probably not in the right spot as well.
Absolutely.
So that I'll take that LVOT VTI with a pinch of salt, is essentially is what I'm going to say. And the valve area is 1 centimeter square, which is just, oh, sorry, not what AVAV max. What is that? I'm not sure about that indices.
AV max.
AVAV max, just in the bottom frame. So the first number.
This one.
Yeah. Area, isn't it?
This is area, so aortic valve area by velocity.
By velocity. Okay, so 1.0. So this one is on the border of moderate to severe. The planimetry is moderate, and the ratio is moderate. I would probably err on the side of calling it a moderate AS at this stage.
Yeah, I think so too. The aortic, you said DSI was, I think it's 0.33.
0.35 or 0.36 in that ballpark range.
So it's not, I don't think it's severe.
No.
So there's a couple of things I wanted to bring out, and I think you've highlighted most of it. The fact is, in the LVOT VTI, you notice that there was, they all look different. But also you can see the opening and closing click. In this case, you can just see the opening click. You really just want the closing click for the LVOT VTI. So the measurement, I would measure this again. Okay, so I wouldn't trust it alone. I think the aortic valve area, the envelope, I think it's okay. I don't have much more to comment about, but the aortic valve planimetry, I think, is too late in terms of where they've measured it, and they'll definitely, measure it at mid systole when it's like open at the max. So there's a couple of factors. The other thing I wanted to bring about or bring your attention to is, if all of the things are correct, your LV systolic output, index Doppler output, is 21.4 or 5 or whatever. So that's reduced. He's got a reduced output, cardiac output. And so that's important to be mindful of, particularly when you're measuring your aortic valve severity, stenosis severity. It's not fair in this case. We haven't given you the whole echo parameters, and you would have done it what we did in the previous case. But I think just it's a side note that to be mindful of and look at in terms of your assessment for the aortic valve. Moving on, I think, Rami, you can continue on with this one.
So just looking at the long axis view, just eyeballing it, it looks like the septum is thickened. The contractility appears normal to me. The aortic valve, again, and the right cusp is a bit more brighter. Maybe there's some calcification, and the opening is appearing restricted, obviously, at this stage. The LA looks big, and the mitral valve looks abnormal as well. The opening of the mitral valve is restricted. I would like to put a color on this and see if there is a regurgitation on the valve. That's what I can say on the long axis. And now putting an M mode through it's through the LVOT and the aortic valve, isn't it? The M mode. I can see. I'm not really that good at these things, to be honest, but I can only see that the right cusp is obviously brighter, and it's moving okay. And the opening, we can actually measure the aortic valve opening in the M mode, I suspect, and during mid-systole and systole over here, and seems to be almost 1.5 to 2 centimeters the opening. And yeah, to be honest, I'm struggling on this one.
Yeah, no, that's fine. I mean, the M mode is quite helpful to try and see whether the valves are opening or closing in a I guess in a 2D telemetry or 2D fashion. And I was just pointing to the screen, but what you can see is kind of like a box shape open where my mouse is. If the aortic valve is opening, so the top leaflet and the bottom leaflets, they open like a box, and you know that the valve is opening nicely. If it's like narrow or closed like that, then you know that it's going to be stenosed or have some sort of degree of stenosis.
Gotcha.
So that's how you can use or help to try and figure out with the aortic valve. Any comment on this? Looks like the aortic valve is still.
It's opening. I mean, you can see in the mid-systole there is an opening there, but it looks restricted to me, especially, in fact, the right cusp is looking more restricted than the left one.
Yeah.
Here you can see, I don't know if I'm really saying it correctly, but I think almost the non-coronary and the right cusps are fused, and it looks like it's become functionally bicuspid. I
think so. It does. So can you guys see that? It almost looks like functionally bicuspid. But the flow or the aliasing velocity didn't look that bad across that valve. But obviously, I would look at different views. What does this help you with?
Okay, just going through the basics. The right side looks all right. The left ejection fraction, left ventricular contractility, just eyeballing that, it looks it's a bit reduced. Now, the mitral valve, I had my suspicions about it, and it kind of confirms that the medial leaflet is calcified and thickened, and there's this extra bit which is floating around, which loath to say there is a vegetation. It's probably not a vegetation. It's more like a.
It's more like a calcified.
It's more like a calcification, yeah, and a big LA, obviously.
Yeah.
The LVOT and the aortic valve in this image.
Looks like there's a bit of aliasing velocity there, and the LV function.
I thought it's mildly reduced. It's probably, I mean, if I have to just eyeball and say it is around 40-45%.
Yeah,
but
maybe low normal.
Maybe low normal, yeah, but we'll have to measure and see. It's one of those where I can say it's definitely not 60.
Yeah. VTI, so LVOT diameter.
Measured almost at the insertion of the cusp, and it's 1.8, which is just about normal. I don't know the age of the patient, but they are a normal adult, so that's just about normal. Maybe I would have measured it a wee bit lower down.
Something there, yeah.
Yeah, but yeah, 1.8 is
1.8. It's so it's on the low side of normal, but I'd be just there may be just a small lady. AVI telemetry, I mean 1.6, but
1.6, yeah.
This trace could be anywhere, to be honest. I'm not sure.
Getting a good image is so important.
Yeah. Okay, so
yeah,
this is the mean grade in the Vmax.
The shape looks more normalish, early peak, and mean grade max is 52, mean is high as well, 32. So they both fall in the moderate category, at least in terms of categorization with ASC classification. In terms of flows, the AV-VTI is 84. Obviously, going back to the LV-OT-VT, I can't remember that now. We'll have to do the dimensionless index. Yeah. 21. So yeah, that one is falling into the severe category. 21 divided by 84 will be just about severe, 0.25. Area Vmax is 0.8, again in the severe category. But overall LVOT-VTI is normal, 21.2. So probably severe.
So this is what you had.
Yeah. If this is all I had, then severe. ABBTR, AB 0.6, TSI 0.24, gradients, although low, and with that ejection fraction, which is slightly subnormal, I feel, but looking at the VTS normal. Severe.
Anything else from this? So you've said, anything else that's important to mention?
The fact that Vmax and the mean gradient are not in the severe category, does that mean anything is what I'm thinking, but you said systolic VI is low, 22.24. That helps me making the decision that it is actually severe.
Might be reduced. So what would you do in this case?
To confirm or refute the findings is what you're asking?
Yeah.
Sorry, guys, can anyone else help me?
That's a hard question. So this is a case of where you've got some parameters of like in the moderate and some parameters in the severe, right? You've got your measurements in the moderate category, your aortic valve area in the severe category, but most importantly, I mean, and your DSI is like, in the severe category. But so you've got a couple of moderate, couple of severe. But the important thing is that you've got your stroke volume, which is reduced. Normal index stroke volume is 35 or more. Anything less than that is reduced. So this will be in the context where you've got a normal ejection fraction, but a reduced stroke volume and a reduced gradient, but the area is in the severe category. It will be a paradoxically low flow state. You see this commonly in patients who are like small, hypertensive ladies who've got, very thick, a thick LV, and the LV is really not able to fill up with the greater number of volume, or it's reduced as a result. So in this case is where I would consider like looking at other parameters or other measurements, and this is where like the DSI will be quite helpful. But also looking at whether a calcium, so CT calcium score, and a calcium score of more than I think 1,200 in men and 2,000 in women are considered severe. You'd also, more importantly, do what's called a dobutamine stress echo. And this is to see whether the stroke volume increases. And usually in this case, the stroke volume would increase and the severity of the mean gradients would not be that bad. But it's like, this is where I'd say, I've got a couple of parameters in the moderate, a couple of in the severe. My stroke volume's low. I'm going to do a stress test on her, a dobutamine stress test, and really try and figure out what the gradients are. And I think that's quite important. And if these patients are symptomatic, you would definitely consider doing a valve replacement for these. So this is the flow. You can get this from the European Society of Cardiology guidelines. It's quite helpful to try and figure out what's going on. I mean, we generally looking at the high gradient aortic stenosis, the Vmax of more than 4, the mean of more than 40. If they have that, then they've got aortic stenosis, right? The severe aortic stenosis, unless they've got some other cause of high output states, and that's when they've got renal failure. So really, obese patients have high output states or anemia. So all those things are important to correct or consider when you're doing those assessments. If they've got a low gradient aortic stenosis and you're not hitting those benchmarks of severe aortic stenosis, in other words, your Vmax, your velocity is reduced, your mean gradient's reduced, look at your aortic valve area, which is what we did in this case, and it was less than 1, it was 0.6, then just make sure that you've not incorrectly measured it. Remember, there was all these other variables of the way that you could measure it. And if it's correct, if you're happy with the measurements, or whoever done the measurements and it's like, yeah, I still think, the aortic valve area is fine, or we measured correctly, you look at the flow state. In this case, the flow state was reduced, so less than 35 mils per meter squared. And then you've assessed the LV. We thought, I mean, the LV looked probably low normal. So I'd probably say it was either somewhere around 50. Then you look at other parameters to see whether you've got, to try and help you out to say whether this is moderate or severe. And this is where I'll probably use like a calcium CT to try and help me differentiate. Alternatively, I can definitely, if the LV is down, particularly as Anil thought. Sorry, I've been calling you Ramni all this time. It's Anil. My apologies.
That's all right. Anil Ramnani is my name anyway, so it's okay.
Sorry, I'm so sorry. I will use the Dimensionless stress to try and figure out, and that looks at the contractile reserve of the LV. Because if there's a reserve, and if the LV is really contracting, and the valve is then able to either open up properly, because now it's got that gradient across, or it's got that forcer, then that's when you call, okay, well, this is where you call the pseudo-severe aortic stenosis. If it isn't able to open up, and it is stiff, but you've got contractile reserve and you're able to hit those gradients, and now those gradients with the Dimensionless stress echo, you're getting your Vmax of more than 4 and your mean gradient of more than 40, this is severe aortic stenosis, or what is also known as low flow, low gradient aortic stenosis. Okay, so that's why I mentioned earlier before, it's important to try and figure out your gradients, but also to understand what the flow state is, because that will determine your ability to measure the gradient across the aortic valve. It also impacts on whether the aortic valve can open or not. And then your clincher is really a Dimensionless stress, because it looks at the contractile reserve of the LV, whether there's any reserve, and if there is, and is the aortic valve opening or not. If it's not opening, it's severe aortic stenosis, and that's if you meet all those benchmarks. If it is opening, hooray! I mean, the aortic valve's opening. That's pseudo-severe aortic stenosis. But I would still consider doing the other integrated approach and say looking at this calcium CT scores to see what the valve calcification is, and also the clinical history to determine what the symptoms are, because it would dictate in terms of how to measure that. So how you classify the severity of the aortic valve. Does that make sense?
It does. Just a quick question over there. The debit mean flow is a yes, and then you go to the reassessment of the aortic valve area. But if the answer is no, what does that no mean? Are we unable to do it, or the patient is unable to mount a response to debit mean for whatever reason? Is that what it is? What
it means is the aortic valve is actually opening it up, so it's more than 1 centimeter squared. So because when you have a low flow state, the aortic valve doesn't necessarily need to open up. It just, because of the and whatnot.
I get that.
But when you get the LV pumping and you get the gradient across, you got the contractile reserve, and it's able to open up, then happy days. Then you'll get the aortic valve area of greater than 1. In some cases, you will get where there's no contractile reserve. You're flogging a dead horse.
Mm-hmm.
That's where it becomes, that becomes difficult, and you may, in terms of how do we manage this patient? Is the cardiomyopathy secondary to the aortic stenosis, or is there another cause of their cardiomyopathy? In other words, is there ischemic cardiomyopathy or infiltrated cardiomyopathy or whatnot that's causing this for their reduced LV? Because then my question is, by replacing the aortic valve, and I'm assuming that they've got severe aortic stenosis, is it going to make any difference in terms of their long-term longevity? And that is a difficult choice, and usually you'll sit down with the surgeons and a number of other people before deciding to whether to operate or not, and you'll try and get as much information to determine that whether it is severe or not. So that becomes difficult. But in most other cases, what usually happens is the LV is probably asleep, not pumping as efficiently, or you don't have enough flow across. But once with the Dimensionless, you do get increased flow, then you can hit the benchmarks of the gradients, and then that will help you out.
Sure.
Make sense?
Yep.
I will leave it at that. I had a couple of other cases. Let me see if I can see, quickly go through them. 85, ischemic cardiomyopathy, outpatient echo. LV's significantly down, aortic valve's not really opening. You got some LEAcing velocity, diameter, LVOT diameter is 2.3. Mitral valve, you got a bit of MR, bit of calcification in the posterior leaflet. The aortic valve is severely restricted in terms of its flow. Going across, and again, there is an opening there, but it looks like it's heavily calcified. RVOT VTI is 16. Again, gross LV dysfunction. They've got a pacemaker lead in there, it looks like. And I would probably say severe LV dysfunction in this case. Going across, LA is dilated. Going. I'm just wanting MR, at least moderate. And side note, we're not doing MR in this case, but the LV is severely down. Your MR, or mitral regurgitation, is going to be underestimated. Again, you don't have that force to get that. So when you do that talk, you'll come across, when someone does that talk, you'll come across that if not already. Pumping through, your aortic Vmax is 2.3. Your max gradient is 21. Mean gradient is 12. Not really hitting any of those benchmarks, but remember the LV is significantly down. So aortic valve VTI was 52. LVOT VTI was 17. And again, I'm not really happy with the measurements of that. There's no closing click. They've set a DSI of 0.33. So in summary, your aortic valve area is 1.3. Your mean is 12. Vmax is 2.3. Your stroke volume is okay, but I'm not sure in terms of the measurements. I'll go back. The DSI is 0.33, but the LVF, they said it was 30. But what I wanted to highlight in this case was the fact that this is a low flow, low gradient, moderate aortic stenosis. Because of the ADSI, but the LV is quite significantly impaired. The flow was also impaired. So this is where I'll do a vitamin stress echo to really see what the measurements are and go down this flow chart and try to figure out what the severity is. So I find this flow chart quite helpful in terms of differentiating, particularly when there's low flow state, because it's quite helpful where it becomes tricky in terms of your assessment. But most cases, if you've got normal flow states, and if you've got either high gradients or high velocity, or low gradients, low velocity, it's easier. But it's just tricky when you have the low flow states. That's when you have to do the other parameters to help you out. Okay, I'll leave it at that. Any other burning questions? No. All right.
Thank you.
No worries.
Thanks
Peace
a lot.
out, guys. Thanks for your time. See ya.